Good morning, everyone, on this beautiful fall morning in Seattle. If you're in Seattle, hopefully it's sunny where you are. We'll give it another minute as people are logging on before we get started. All right. Good morning, everyone. This is our November AIDS Clinical Conference, and it's my pleasure to introduce Dr. Brian Wood, who is no stranger to the AETC community. He is an associate professor of medicine at the University of Washington and is well known in his role as medical director of the Mountain West AETC and a superb educator as always. And he is returning to give our yearly ART update. So thank you, Brian.
Thanks, Tricia, and thanks for having me back. You may have given me a little promotion there. I am director for our ECHO program, not the whole AETC, just to clarify. But thanks, Tricia. Honored to be back. Thanks, everyone, for joining. What I'm going to try to do is review the most recent update for the treatment guidelines for adults and adolescents and highlight some of the most recent medications that have been approved and that are in development, especially the long-acting things that are coming. I won't be doing an update on PrEP or talking about those long-acting agents as they relate to PrEP, which they will. Rafi Landovitz from UCLA is planned to come here in April, and he is a world expert on long-acting agents for PrEP, so I'll defer that piece to him. So I will focus on adult and adolescent treatment. I will be sharing data for medications. I will be giving some opinions about medications. I want to be clear that I have no disclosures or conflicts of interest. I will also be sharing some polling questions, not meant to be quizzes, just meant to get the thought process and juices flowing and stimulate some thought and discussion. So I will be focusing on updates that came out in June to the Department of Health and Human Services, adult and adolescent treatment guidelines. I'll intermix a little bit of where the IAS USA guidelines either agree or disagree. But this is what I will focus on. I'll give you the updates. I'll share what the guidelines committee put in their guidelines as of June. And then I will also intermix controversies, questions, gaps, and some questions for you to think about. Let's just start with a question to, again, just get the thought process and discussion going. So, not meant at all to be a quiz, not meant to say there's one right answer, but if you're considering initial ART for someone, what do you think is the best option? I've listed for you here the options as they are in the guidelines. We'll just give you a few seconds here to weigh in. Again, no right answer. I'm curious what you think. And let's presume a person has a negative B5701. Let's presume there's no major drug interactions and the person just says, hey, what's the best option for first therapy? So thanks everyone for weighing in. We won't spend too much time on this one. Not surprisingly, Bictegravir FTC TAF is by far the winner. That is the one I reach for most in the clinic as well. And if not approved, then I start reaching for those second two. I couldn't get anyone to jump for a 2-drug option up front or for something else. I think this is really reflective of clinical practice, but I'll also bring up where some of the questions and perhaps controversies come up. In the left here, the purple heading is the most recent recommendations from the Department of Health and Human Services as of June. The categories are recommended for most people with HIV, or the category I'm not showing you is consider in certain circumstances. The recommended for most people here, as you can see in no particular order, is bictegravir with FTC TAF, the dolutegravir with two NRTI options, or the two-drug option dolutegravir lamivudine with several caveats there at the bottom. Not 100% sure why the guidelines committee put dolutegravir lamivudine in the recommended for most people with HIV. The list of caveats here to me is just the definition of consider in certain circumstances, but it did make it there. I think for practical purposes, most providers are reaching for the bictegravir FTC TAF option, or again, if not covered by insurance, one of the dolutegravir with tenofovir options. I don't know about you, but I've gotten largely away from starting or offering individuals the abacavir option at outset, even if B5701 negative. It's a large pill. I don't find it to be as well tolerated. There's some cardiovascular concerns, which we'll talk about. You can see on the right the list from IAS USA, not updated as recently, but it largely agrees, with the exception that it has actually officially eliminated abacavir as the first line option. The main change we saw in June from DHHS was the removal of raltegravir from recommended for most people with HIV, and I'll come to the next slide on why. I will pose a question for you that I don't think has been answered, and I think will evolve in coming years, is, are there some individuals who would benefit from starting an option that's not on this list, a non-integrase inhibitor option, perhaps an NNRTI? We'll talk about the weight gain issue, which still is perplexing and a very hot topic, but I'll just leave that to you to think about. Are there some individuals who would benefit from an option that's not on this list? I don't think we know. Both guidelines now have some official language about the weight gain issue, and both clearly say the data is not compelling enough yet to affect our choice of initial therapy, but I think that will evolve. Why was raltegravir moved from recommended for most people with HIV to consider in certain circumstances? These are the reasons cited by the guidelines committee. Number one, the concern for dolutegravir raising the likelihood of neural tube defects has really gone away as data has accumulated, and dolutegravir is back to preferred for conception and pregnancy. So what they highlight is there's really no reason now to choose raltegravir over dolutegravir. In addition, raltegravir has a lower barrier to resistance and a higher pill burden. And you can see there at the bottom the updated data for dolutegravir when used at conception by a person of childbearing potential, the estimated rate of neural tube defects at about 2 in 1,000. The initial data from this study suggested it might be as high as 1 in 100, which was alarming, but really, as data is accumulated, that concern has gone away. So that is the thought process behind removing raltegravir. But let's turn to a case to get a little bit at some of the more controversial aspects here, the bigger questions. This is a real case. I shared something similar last year, but I would like to hear your opinion on a couple of questions here. This is a 55-year-old Black cisgender man. I've known him for years. His HIV diagnosis was in 2010. He initially took efavirenz with TDF and FTC, that's brand name Atripla, till about 2016. Viral loads were routinely suppressed on that regimen. One lapse in adherence in which he had viral rebound, but no resistance documented. At that time in 2016, he switched to dolutegravir, abacavir, lamivudine. He was B5701 negative. We thought this would help with depression. Around that era, I feel like that was a fairly common switch, at least in my practice, and his viral loads have been suppressed since. You can see there his comorbidities. And what I'm getting at is a concern for cardiovascular risk. This individual certainly has metabolic syndrome and what I would estimate would be elevated cardiovascular risk, importantly, no hepatitis B. So again, by way of stimulating thought and discussion, I'd like to ask you this very simple question that may not have a simple answer. And let me launch the poll. There we are. How much do you worry about abacavir and cardiovascular risk? I just want a general gestalt. Not much, a little, moderate amount, some, or a lot? I'd just like to poll the community here and see what you think. While you're thinking about that, appreciate the questions in the Q&A. Michael, starting someone on Cabenuva isn't currently recommended. Cabenuva is really only recommended, as we'll talk about, for someone with a suppressed viral load to transition as maintenance therapy. We'll talk a little more detail about some of the considerations there. Waiting, the viral load limit for dolutegravir lamivudine was because of the initial design of the Gemini trial, in which only people with viral load below 500,000 were enrolled. We have now seen published a study called STAT, which was a single-arm dolutegravir lamivudine right up front as initial therapy with any viral load and before genotype. And it worked well in that single-arm study. So I think maybe we could use it with a higher viral load. That said, practically, at least for me, I don't really see a need for 2-drug therapy at the outset, since we have well-tolerated 3-drug options. I like that option better as maintenance personally, and have not prescribed dolutegravir lamivudine for initial ART personally, but per the guidelines, it is an option to consider. Let's come back to abacavir. A bit of a spread here. A little to a moderate amount would be the most common answers. I think this question remains controversial. For me, over the years, my concern, I think, has increased from maybe a little to a moderate amount. I won't delve into the data too much because that could be a talk in itself, but just to summarize why we raise the question, why we have the concern. In the initial randomized clinical trials for abacavir, there really was no signal for elevated likelihood of cardiovascular events. That said, those are carefully selected patients, limited follow-up of the clinical trials. If you go look at the observational studies, the systematic reviews, those do start to find an association between abacavir and ischemic cardiovascular events, whether it's MI or stroke. Not all of them, but most of them, I would say, find an association. There's some concern there for channeling or selection bias. We often steered people to abacavir if they had renal dysfunction, which may indicate they have other risk factors for cardiovascular disease. That said, these studies are pretty consistent in finding an association, including when they try to control for those factors. What is variable and what I struggle with a bit is if you look at these studies, it depends on the study you look at, whether the association is with current use of abacavir, cumulative use, or recent use, usually designed as being within the past 6 months. But it's a pretty consistent finding with some varying details and definitions. However, what has started to convince me more, in addition to some anecdotal cases in the clinic, is accumulating data that there is a plausible or credible biologic mechanism. And again, I won't go into a lot of detail here, but if you're interested in this, I put some references there. And it is now consistently found that abacavir causes platelet reactivity and activation of platelets, leading to an inflammatory or prothrombotic phenotype that really, I think, is plausible that it contributes to endothelial dysfunction and instability of atherosclerotic plaques. What do we do with this in clinical practice? I have patients like the person I presented to you who've been on abacavir for years and seem to be doing fine. That said, for every individual taking abacavir, I at least consider what is their cardiovascular risk, what are the other options, and have a conversation about potentially changing. So that's a good jumping off place for this question. So let's come back to our patient. Let me launch this poll. So again, he's been taking dolutegravir lamivudine for years. He feels fine on it. His viral load's suppressed. He's not quite sure why, as a provider, I'm bringing it up, but also has a lot of cardiovascular risk factors. So what would you recommend? Again, no documented resistance, no hepatitis B, and let's presume that insurance is not a barrier here. What would you recommend? And thank you all for weighing in. Again, no right answer, and I'm going to keep us moving here. So kind of a spread here. I couldn't get anyone to go for IM-CAB rilpivirine, but it looks like the winners are BIC-FTC TAF and dolutegavir lamivudine. I think those are very reasonable. Dolutegavir rilpivirine would probably be reasonable as well. I sort of like dolutegavir lamivudine here because I think he's a good candidate and he's already been taking those drugs. We know he tolerates those drugs, but I don't think there's a right answer. And I use this to stimulate thought about maintenance ART or switching to 2-drug ART. So this is what is currently in the guidelines. I think there's a couple important take-home points here. So 2-drug maintenance ART, and that means a person has a suppressed viral load on a more traditional 3-drug standard regimen, and then we switch to maintain the suppressed viral load to something with only 2 drugs, is a reasonable option to consider if, and these are the important points, that person's HIV is susceptible to both drugs and they do not have chronic hepatitis B. An important point because none of the 2-drug options would be effective therapy for chronic hepatitis B. Now, the update we saw in June to the guidelines really focused on long-acting cabotegravir rilpivirine. You can see there at the bottom some of the abbreviations used related to this regimen. And let's talk about 2-drug options, the oral options first, and then the long-acting options. So the guidelines list what they say are examples of successful 2-drug maintenance options. We've discussed these before, so I won't belabor them. Dolutegavir rilpivirine, that's trade name Juluca, is a reasonable option. And I'm putting here a brief summary of the data and participants who were included in the trial, because I think those criteria for inclusion are really key. And the overall point is these are individuals who have long-term viral suppression, no history of resistance or concern for resistance to these 2 drugs, and again, no hepatitis B. Dolutegavir lamivudine is also approved not only as an option for initial therapy, as we talked about, but for maintenance therapy with similar caveats. Now, a question that comes up for me is what are the long-term benefits of these over 3-drug ART, for example, with TAF? And I don't think that question has been fully answered. A major limitation, in my opinion, of the data for dolutegavir rilpivirine is it has only been compared to TDF-based 3-drug regimens, not to TAF-based 3-drug regimens. Dolutegavir lamivudine has been studied in a large trial called Tango and compared to TAF-based 3-drug ART, and we've seen data out beyond 100 weeks, and there's no real clear benefit in terms of tolerability or side effects, at least with that amount of follow-up in this randomized trial to dolutegavir lamivudine compared to TAF-based 3-drug ART. But I think we need more data. I think we need more follow-up. There is an ongoing study comparing maintenance therapy with dolutegavir lamivudine to bictegravir FTC TAF. That trial is called Paso Doble. Someone got very creative with the Spanish ballroom clinical trial names. And we may learn more from that, but I think we need more follow-up and long-term data to really help us understand the benefits of eliminating TAF from our regimens. The other 2-drug options in the guidelines cited as having enough data that we could consider them are a boosted PI plus 3TC, particularly boosted darunavir plus 3TC as 2-drug maintenance. There was a study with 250 or so individuals that found that to be successful. And similarly with boosted darunavir dolutegavir, a published study had about 275 individuals. There's no published trials on 2-drug maintenance with dolutegavir doravirine yet, but there is one upcoming, and that is an option we have used for certain individuals in clinical practice. Let's talk about the long-acting therapy though. And another poll I'm curious to ask you, how many individuals do you have currently receiving IM long-acting cabotegravir rilpivirine? I'm going to anticipate the numbers are going to be small, but I'd still love to hear from everyone on this. Thank you all. I love this. Thank you very much for weighing in. So 80% 0 patients, 18% 1 to 5, one individual over six patients or clients receiving this. So that's fascinating to me. I have 0, which I will say right up front. So my clinical experience with this is really limited. So for those of you who do have more experience, please feel free to share in the chat box or Q&A. To Jenny, let me come back to that question. I'm going to present a few considerations here and then we'll come back to that. So for those of you with more experience than me, practical experience in clinic with this, please feel free to weigh in the chat or Q&A. Well, let's just talk about Cabrylpivirine. This is trade name Cabenuva. So this is a long-acting intramuscular injectable. And this summary comes from David Spock and the National HIV Curriculum. On that site, we have more details and slides summarizing all of these trials. So for more detail, please see that site. Focusing for a moment on the phase 3 trials, FLAIR, which stands for First Long-Acting Injectable Regimen, compared IM monthly cabrylpivirine after 20 weeks of dolutegavir, abacavir, lamivudine to achieve a suppressed viral load, and after 4 weeks of an additive oral rilpivirine to document tolerability, compared to starting and continuing dolutegavir, abacavir, lamivudine. We've seen data from that trial out to 96 weeks. Similarly, you can see there the Atlas and Atlas 2M trials, for which we also have published 96-week data, and for which I will show you a little bit more info. This is what's in the FDA package insert, the FDA approval and package insert for starting IM long-acting cabotegravir rilpivirine. So again, this is for maintenance therapy. So this is for replacing an oral regimen in persons with documented and sustained viral suppression. It is written in the package insert that this is for a person taking a stable oral ARV regimen with no history of treatment failure and no known or suspected resistance to CAB or rilpivirine. I would personally change that wording just a little bit. I think a person can have a history of treatment failure and still be a candidate. For example, if their only resistance was a K103N, and in the FLAIR and Atlas trials, a K103N was allowed, then that person may still be a candidate. I think the important thing is no known or suspected resistance to cabotegravir and rilpivirine, and again, no hepatitis B. This would not be an effective therapy for hepatitis B. These slides, again, come from the National HIV Curriculum. This is the recommendation for the oral lead-in. We'll come back and talk more about that. And then the initial injection, which is a loading dose, followed by continuation injections. And what is approved to this point is monthly dosing. Please note the difference in the loading dose and the monthly continuation injection dose. And please note this is only recommended to be given in clinic, and it is 2 IM injections each clinic visit on opposing gluteal sites, or at least 2 centimeters apart. So an individual needs to commit to coming to clinic every month for these injections. I won't spend a lot of time on this because I think, again, not many of us have individuals receiving this therapy, but if you do, please know there is guidance for bridging with oral versions of cabrylpivirine for planned missed injections, and there is some guidance for what to do with unplanned missed injections and the timing if a person comes back into communication or clinic after having missed an injection. Some important notes: if it's been over 2 months since the last injection, what the package insert says is really reassess clinically. Is this the right therapy? Is it okay to resume? They don't specifically say it, but that's a situation where I might check a viral load and really have a conversation about ability to adhere to the monthly visits. And also, I think important to note, if a person stops IM cabrylpivirine, these drugs are very long acting and may stay in the system in systemic circulation for up to 12 months or longer. So the package insert makes a really I think, important point that even with stoppage of this therapy, a person needs to commit to adherence to oral ART, because if they don't, there will be low levels of these drugs and resistance can develop. So I think we're in this interesting era where we finally have long-acting injectable ART as an option, but very few of us have prescribed it. In my opinion, there's a bit of a catch-22 here, where we waited so long for long-acting IM therapy, but these are drugs with low barrier to resistance that stay in the system a long time. And we want to offer this therapy to individuals who, have challenges with adhering to pills, but those also may be individuals in whom we, don't feel confident they will show up every month for their injection, and we worry about resistance. I also have had a lot of conversations in my clinic with individuals where I say, look, we have long-acting therapy. You just have to come to clinic every month. And they say, taking my pill or my 2 pills at home every day is easier, and I prefer that to coming to clinic every month. So it's exciting that we have long-acting therapy. There certainly are limitations. And Jenny, I think that brings me back to your question. So for the person who's struggling with adherence and has a detectable viral load, I worry about this being the optimal option. If they could have excellent adherence, maintain a suppressed viral load for a while with no resistance identified, with no hepatitis B, perhaps this is an option. But again, I think they'd really have to commit to coming in regularly, not missing any doses. And if they miss a dose or they stop cabrolpivirine and then don't take oral ART, that may increase their likelihood of resistance. And when a person develops resistance on cabrolpivirine, it's significant resistance. It's significant NNRTI and or integrase mutations. So I think these are some of the considerations and also some of the concerns that have prevented us from prescribing this more. Ben, it's a great question. I will come back to that. And the implantable is more for PrEP. So I won't show you a lot of details about the implantable, but I will come back to that in a bit more detail. So thank you for asking these questions. One other note about choosing individuals who may be good candidates for IM cabrolpivirine. I think there are some outstanding questions about the data we need before starting it. So I've mentioned this is really an option for individuals with long-term suppressed viral loads on oral ART, who are willing to commit to coming to clinic for the injections, who understand that if they stop the injections, they really need to adhere to oral ART, and who don't have any resistance to cabrolpivirine and who don't have any hepatitis B. Now, in the big phase 3 clinical trials, FLAIR, ATLAS, ATLAS-2M, which only enrolled those carefully selected individuals, there were 13 confirmed virologic failures. You can see here 13 out of just over 1,000 participants at 48 weeks. Excuse me. This group of researchers looked at those 13 individuals, and in a logistic regression analysis, the multivariate part of their logistic regression analysis found these to be factors associated with a higher risk of confirmed virologic failure. Again, this is narrowing this already to very carefully selected individuals, and then looking at the very small number with confirmed virologic failure. These were factors that increased the likelihood of not succeeding in terms of viral load suppression. And the first is subtype A virus. That seems to be a factor. That subtype really predominantly exists in Russia. Here, we don't see a lot of subtype A, but if you are seeing an individual from Russia, it may be worth knowing their subtype. 2 or more baseline rilpivirine resistance mutations found by an archive or DNA genotype seem to be the most significant factor. Again, these were individuals who, when they enrolled in the trial, had no known rilpivirine resistance, no rilpivirine resistance documented in the chart or in RNA genotypes. But then on confirmed virologic failure, they went back and did archive or DNA genotypes. And those individuals who had 2 or more archived rilpivirine resistance mutations did have an increased likelihood of virologic failure. BMI above 30 came out in their analysis as a predictor. and then lower rilpivirine trough concentrations. But importantly, no one, importantly, it was really individuals who had 2 or more of these predictors who had virologic failure. Very few who had 1 or who had less than 2 of these factors had confirmed virologic failure. And importantly, BMI above 30 on its own was not a predictor. So I don't see that as a contraindication. And then at the European AIDS conference last month, we saw a trial, I've listed this here at the bottom, that looked at all of the participants in these studies and just looked at BMI above 30 compared to below 30, and there was no difference. So BMI above 30 alone is not a contraindication. I've seen it written that maybe with BMI above 30, we should consider the injections with longer needles or things like that, but really it's only if people have multiple of these predictors, we might pause. Again, this is after narrowing to individuals with documented resistance, suppressed viral loads, and all of the other things we described. Other outstanding questions for IM cabopivirine: what's the role of every 8-week dosing? So I have this note up here to remind you that the FDA is going to rule on every 8-week dosing by the end of December. So I'll talk more about that. Is the oral lead-in necessary? I think that's a very intriguing question, and I'll show you a little more about that. And then how high is the risk of missed doses or stoppage of oral ART after concluding long-acting IM injectable therapy? I don't feel like there's a lot of collective clinical experience, or at least enough to answer that question fully yet. But for those of you who have more patients or clients on IM cabopivirine than I do, please feel free to weigh in and share your experience. For a moment, let's talk about every 2-month dosing. So right now, IM cabopivirine is approved to be given in clinic every 1 month. This trial, called Atlas 2M, enrolled some individuals who had been in Atlas and rolled over, and some who had never received IM cabopivirine, and randomized them to every 8-week or every 4-week dosing. The punchline is every 8 weeks seemed to work very well. And I presume the FDA will approve every 8-week dosing. How that will change their guidance for bridging missed doses, for stoppage and things like that, I think is to be seen, but the FDA should weigh in on this by the end of December. The other really fascinating question: is the oral lead-in necessary? And the answer is it may not be. So right now, what is recommended is 28 days of oral rilpivirine and oral cabotegravir before switching to the IM version. What happened is, when this was being developed, there was concern about a hypersensitivity reaction, and the thought process that, look, these are very long-acting meds, we can't get them out of the system. If a person has a reaction, we should do an oral lead-in first to document tolerability. And then in those big phase 3 trials, no one had any issue with the oral, during the oral lead-in. No one had a hypersensitivity reaction. No one had a serious adverse event. So in this study, just published last month by Chloe Orkin and colleagues, they took individuals at the end of the FLAIR trial. Again, that was a study of IM cabopivirine compared to dolutegravir, lamivudine. And at the end of the trial, gave them the option to either continue or withdraw, gave them the option of doing IM injectable therapy or oral ART. And if they chose, so this is all participant choice, if they chose injectable therapy, gave them an additional choice of either doing an oral lead-in of 28 days, as is currently recommended, or direct to inject. That's the term being used, meaning skip the oral lead-in, go right to injections. And here, the key finding is there was no issue with going right to injections. There were no major adverse events. There were no differences in drug levels. There were no differences in efficacy. So currently, what is in the FDA approval is still a 28-day oral lead-in. My understanding is in Europe, they are approving cabopivirine injectable with a optional oral lead-in. My understanding for IM cabotegravir for PrEP here is the oral lead-in will be optional. And I think this gives us at least some flexibility in making the oral lead-in for IM cabopivirine either shorter than 28 days or potentially optional if the oral lead-in is what's presenting a barrier. Again, this is still individuals with suppressed viral load, with no hepatitis B, with no resistance to either of these meds. That was a mouthful on IM cabopivirine. Please feel free to jump into the chat box or Q&A with questions or thoughts or share your experience. But otherwise, I am going to turn to another case, and I'm going to turn to the weight gain issue, which again, still seems to dominate conferences, a lot of studies, a lot of conversation and controversy around ART. And I think it remains an important issue that we need to understand better, especially because of the implications for things like cardiovascular disease, metabolic syndrome, NAFLD and NASH, of which we see a lot. Charles, appreciate the question. So again, not based on my clinical experience, I don't currently have any patients in my clinic receiving the injections. However, in the trials, what I would say is injection site reactions were common, but they were mild and generally transient, and in general did not limit use of the IM cabopivirine. It was incredibly rare for people to stop the injections because of injection site reactions. So there may be a bit of pain. It's usually mild, it's usually transient, and lasts in general less than 3 days, and usually is not limiting. It's a great question. But why don't we turn to this, another case for you to think about, another real case from my clinic I've recently been thinking about, and again, I don't know the right answer. So I'll open the poll here for you. As we think about this, so this is a case of weight gain while taking an integrase inhibitor and TAF and what you would do, and I've given you quite a few options to contemplate here. So this is a 40-year-old woman born in sub-Saharan Africa, had immigrated here a few years ago, while in her home country, received ART first with nevirapine, 3TC TDF, and then efavirenz, 3TC TDF, so 2 NRTI-based options. She moved to the US in 2019, at which time her ART was switched to dolutegravir FTC TAF, really with the goal of, hey, let's give you something updated, first-line therapy here. Since that time, her viral loads have remained suppressed. She has gained a documented about 30 pounds, and she feels quite bothered by this and quite concerned about it. You can see there her comorbidities. So I'd love to know what you would do here. Would you continue the current regimen, or would you switch? I've given you lots of options. I love that a couple folks are going to something else. I'd love to hear what something else is. Please feel free to write that in the chat or Q&A. All right. So quite a mix here. And I think this just shows how controversial this is and how we really don't know the right answer. So we got some takers for continuing current therapy, for switching dolutegravir to doravirine, for switching TAF to TDF, for switching both, going to 2-drug therapy, or something else. I'm curious what something else is. If, for the brave souls who wrote something else, if you're willing to write it in the chat or the Q&A, please do. So I've talked about this in prior years. I won't belabor a lot of issues, but there was an update to the guidelines in June that I thought was worth noting. So both the HHS and the IAS USA guidelines already had some general language on weight gain, that there are associations with integrase inhibitors, and association has been found with TAF compared to TDF, and that really clinically we don't know what to do with this. The update in the HHS guidelines from June really was an update to the section on considerations for HIV treatment for cisgender women. Now, this is not to say this isn't a phenomenon that affects cisgender men or trans or non-binary individuals. I think there is a consistently greater association for cisgender women than for cisgender men, which is why the guidelines focused on it in this section. And I think there's simply a lack of data for trans and non-binary individuals, but it certainly is a phenomenon that could impact anyone receiving HIV treatment. But there are some really important caveats here, I think. So what's noted in the guidelines is clinicians should consider the possibility of weight gain in women with initiating or changing ART. The underlying mechanisms and the long-term impact on cardiovascular disease, diabetes, pregnancy, and other comorbidities is unknown. I think that is a very important, outstanding question. Also important, it is unclear whether switching to a non-INSTI based regimen results in reversal of weight gain. So those switches we were considering, like a switch to an NNRTI, are being done sometimes in clinical practice, but I don't think we have data to confirm that it consistently leads to reversal of weight gain. And there is significant uncertainty whether the integrase inhibitors cause weight gain or whether the comparators suppress weight gain. And I'll talk about this a little more because, again, I think it's clinically important. So at CROI and at subsequent conferences the past year, we saw a lot of cohort studies confirming this association. So I'm not going to show you all of them. I'll give you an example. This keeps coming up, though, at conferences and in the literature. And I think the associations have become pretty consistent. What I'm seeing more of is attempts to evaluate the long-term outcomes and complications, things like cardiovascular disease, metabolic syndrome. And so I'll just show you this one example. In terms of considering the long-term outcomes, that data is more mixed, but this was just one example. There are more you can go look at from Janet Lowe and colleagues with the REPRIEVE cohort, a large cohort of individuals with HIV age 40 to 75 with low to moderate estimated cardiovascular risk. And they simply looked back and said, let's compare those individuals who've taken an integrase inhibitor for more than 6 months to those who have never taken an integrase inhibitor. And they did some fancy statistics to control for covariates and confounders and use of TDF and TAF and things like that. And just show you here the results. So the top rows, the difference in means, you can see difference in mean BMI and waist circumference. And you can see there, for those individuals who took an integrase inhibitor, there is an association with higher BMI and higher waist circumference. And the association is stronger for those born female than those born male. That is the data that was used for the trial, but there was no association with fasting glucose or fasting LDL. Again, at the bottom, there was a higher odds of obesity, particularly in those born female, but no higher odds of metabolic syndrome or hypertension in this study. Now, this is where I think the data is more mixed, depending on the cohort study you look at. Some do find an association with metabolic syndrome, with hypertension, with cardiovascular risk, and some don't. And I would posit it really depends on who are the participants in that study and the definitions used. So I think the associations with BMI, waist circumference, obesity are consistent. I think the associations with complications are highly mixed and not well understood yet. The other thing we've seen in the past year, though, is more evidence of a plausible biologic mechanism for how integrase inhibitors in particular may be leading to excess weight and may be leading to this, this association, particularly for those born female. So I'm not going to go into a ton of detail here, but if you're interested in the mechanisms, this is really worth looking at. So first, we saw this at CROI from the Atlanta Women's Interagency HIV study. This was a new term for me, metabolomics. So this is really drawing blood and looking at metabolic pathways and metabolic signatures. These researchers compared 18 women with at least 5% body weight increase after switching to an integrase inhibitor to 15 who switched to an integrase inhibitor and did not experience that level of weight gain. And importantly, those women, again, these are cisgender women, those women who gained weight after switching to an integrase inhibitor had a very different metabolic profile in their blood than those women who did not gain weight. And you can see here, they described this metabolic inflexibility, dysregulation of insulin signaling, and storage of excess fat. So similar to Ibalizumab, I think we want a credible mechanism here, and I'm starting to see evidence of that. This mouse model also was notable and got some press. So these researchers from Hopkins administered dolutegavir, bictegavir, or doravirine to female mice, and there were some really interesting findings. So dolutegavir and bictegavir mildly induced white adipocyte differentiation, which can lead to lipid accumulation. dolutegravir and bictegravir strongly affected the mitochondria in brown or beige adipocytes. And really what they did is they suppressed thermogenesis or burning of calories by those adipocytes. Importantly, this includes estrogen-mediated pathways. So this is a plausible means by which the impact of integrase inhibitors on weight may be different between those born female and those born male. And importantly, doravirine did not have any of these effects. And then they tried to get at why is there this association with dolutegravir? And in the in vivo portion, dolutegravir inhibited oxygen consumption and energy expenditure by 15% without raising calorie intake or food intake. So it did not seem to be a stimulation of appetite issue. This also, I think, is really important to note. So we saw this at ID week. So this is a trial of not weight gain, but weight loss, looking at PrEP. So this systematic review included 7 PrEP trials and simply asked the question, what are the odds of greater than 5% weight loss looking at TDF compared to the comparator in the trial, either placebo or cabotegravir. And what you can see here on the right is the odds of greater than 5% weight loss are significantly more with TDF compared to placebo or compared to cabotegravir. They also, again, tried to get at the mechanism. Why is TDF causing weight loss? Is it all GI intolerability and GI side effects? And you can see here, bottom left, TDF was associated with more vomiting than placebo or cabotegravir, but not with increased odds of nausea, diarrhea, or appetite loss. So it is not clearly a GI intolerability issue. But I think what has really come out within the last year or two in the literature is that integrase inhibitors, yes, are associated with weight gain, especially for some individuals. Whether it is associated with long-term metabolic complications is variable and hard to predict. There's become this notion that TAF is associated with weight gain, and I would really challenge you to change that perspective, because I think when you drill down in the data, while there is an association with greater weight gain with TAF, I don't think there's any convincing evidence that TAF causes weight gain. I think there is accumulating really convincing evidence that TDF leads to weight loss. So I actually think the perspective should be there's a difference because TDF suppresses weight, possibly not due to GI intolerability, possibly due to mitochondrial toxicity and other adverse effects we don't fully understand. I would encourage you to consider this in the trial that looked at dolutegravir lamivudine or dolutegravir with FTC TDF. So really the difference is the TDF, there was less weight gain. I think clearly there, it's the TDF suppressing weight. In the TANGO trial, dolutegravir lamivudine compared to dolutegravir FTC TAF, there was no difference. So it's not like the TAF was leading to weight gain. So I know this is a lot on the weight gain issue, but I think it is important to our patients, clients, and in terms of long-term clinical outcomes. So this is my interpretation. Would love to hear your thoughts. Again, I think there's convincing data that TDF and also efavirenz suppress weight. I think there is a lot of evidence now that integrase inhibitors, especially dolutegravir and bictegravir, can cause excess weight, insulin resistance, and a higher likelihood of metabolic syndrome for some individuals, but not all. And I don't think we fully know how to predict that's going to happen. What is new for me in the past year is these credible biologic mechanisms by which integrase inhibitors could be stimulating insulin resistance and weight gain, and credible descriptions of why there may be these differences based on biologic sex. I don't think we understand why for some individuals the excess weight happens, for some it doesn't, for some it happens and stabilizes by 9 to 12 months, for most stabilizes by 9 to 12 months, but not for all. And I don't think we know much about the reversibility. There are case reports documenting reversibility, but we need more data. So my strategy really is case by case. What are the options? And does it make sense to make a switch and see what happens or not? I am not switching ART routinely because of this phenomenon. If you want to read more about the mechanisms in a denser version, I did write a review on those that was just published in OFID, really focusing on the mechanisms and my interpretation And don't forget ACTG 5391, or do it if you have patients or clients who've gained more than 10% weight on dolutegavir, bictegravir, or raltegravir with TAF. They may be candidates for this trial. I'll go to another topic and get into some of the other newer and long-acting agents, unless there are any questions or comments on that one. Okay, well, it's perfect. We're about 10 minutes left. So let's talk about salvage therapy and newer agents, and that will be the last section. So this is another real case. This is someone from my clinic. I'll give you this last, I'm not sure I shared the results of the last poll. If I didn't, you can see them there. But then let me give you the last poll. Okay. So this is someone I've also known for a while. This is a 52-year-old cisgender man, long-standing HIV. Viral load had been suppressed on rilpivirine, FTC TAF, that's Odefsey for several years. Only ART prior to that, you can see there is the efavirenz-based regimen. Unfortunately, at the start of the COVID pandemic, he had a lot of things happen in his life and a lapse in adherence. He had viral rebound to just over 1,000, and genotype showed these new resistance mutations, E138K, which is resistance to rilpivirine, and M184V, which is an NRTI resistance mutation you're probably familiar with. So what would you choose for the new regimen? Please go ahead and weigh in there. Okay, not as much of a split here. Mostly bictegravir FTC TAF as well, in its usual form, 1 pill a day, and some takers for adding doravirine or adding darunavir-cobi. For this individual, we did bictegravir FTC TAF, 1 pill a day, and he's done very, very well. Let me talk a little bit about salvage therapy and new drugs that are coming to end today. So I think this is an important update from the guidelines. You know, the old adage that we always need 3 active drugs in an ART regimen, or need to find 3 active drugs for salvage, I think requires more consideration and more detail these days, because we have these drugs with very high barrier to resistance, dolutegavir, bictegravir, boosted darunavir, and the new language as of June in the guidelines is, in the setting of virologic failure, a new regimen can include 2 fully active drugs if at least one with a high barrier to resistance is included. And that's because of some accumulating data that I will show you. This section was also updated to add descriptions of fostemsavir as part of salvage ART. So I'll talk to you a little bit about fostemsavir, and we'll talk about other new drugs for salvage and new drugs that are coming. So we've discussed the Dawning study before. This was a very notable trial in which individuals who had virologic failure on an NNRTI-based regimen were randomized to dolutegavir boosted lopinavir with investigator-selected NRTIs. The trial was stopped because dolutegavir performed so well and outperformed boosted lopinavir. And importantly, in this trial, there were high rates of M184V with other NRTI resistance. And despite those high rates, dolutegavir did really well. And as long as dolutegavir was paired with 1 active drug or 1 active NRTI, it did really, really well, including at high viral loads. What came out this past year, and I don't think got quite as much attention as it should have, was this trial called Nadia. Some similarities and differences to Dawning. So this was, again, individuals who had virologic failure on an NNRTI-based regimen. It was, again, individuals with high rates of NRTI resistance. And these individuals were randomized to dolutegavir or boosted darunavir, and were randomized as part of their NRTI backbone to TDF or AZT. Here, dolutegavir did not have statistical superiority, but it did have non-inferiority. And importantly, both of these options, dolutegavir or boosted darunavir, worked great if there was 1 additional active drug. And honestly, they worked really well, even if they were paired with 2 NRTIs that had 0 predicted activity. The rate of virologic expression was still 90% in both arms. There were a couple of cases of new integrase resistance with dolutegavir and NRTIs that had 0 activity, so that gives me pause. But I think this is added support and data that if you have a drug with a very high barrier to resistance, dolutegavir or bictegravir or bocedurenavir, and one other active drug in the mix, the person is likely to do really well. This trial has been heralded as the end of AZT. I think it also is, perhaps the end of the adage that we always need 3 active drugs. And again, it's the fact that we have these agents with high barrier to resistance that really makes this difference. There are some additional studies that suggest that a high barrier resistance med with 1 active drug is plenty, but I've shown you the strongest data. So I'll just show you what has become my strategy in the setting of virologic failure if there's resistance and if dolutegavir, bictegravir, or bocedurenavir are an option, if those are fully active, those high barrier resistance drugs. And if I have 1 additional active medication, whether it's an NRTI or something else, then I generally am confident about that. I think if somebody has a sky-high viral load in the setting and you want to add another agent until their viral load suppresses, then narrow to dolutegavir, bic, or bocedurenavir plus 1 active drug, that's fine. But I think there's really good evidence nowadays that a high barrier to resistance med plus 1 active drug is plenty. Now, it's very different if those high barrier to resistance meds are not fully active, or if you don't have an active med to add to those. And that's where we start reaching for these other salvage drugs that I'll talk about. And that's where we really still aim for 3 active drugs. So the last part of this will be a review of salvage drugs recently approved or coming. So fostemsavir is a drug we generally use for salvage. It's oral, BID, generally well tolerated. I have a couple people taking it in my practice. It binds here near where GP120 should bind the CD4 receptor. These are slides from David Spock. These are beautiful illustrations, as David always does. It really blocks this attachment of GP120 to the CD4 receptor, so is known as an attachment inhibitor. Again, well tolerated, twice a day, couple little drug interactions like raising statin levels, but not a contraindication. Ibalizumab is an IV every 2 weeks salvage drug, which is known as a post-attachment inhibitor because it actually binds out here to the CD4 receptor that happens after attachment and prevents conformational changes that would lead to interaction with R5 or X4 co-receptors. So it's known as a post-attachment inhibitor. I don't currently have anyone in my clinic receiving this, but it is used for cases of salvage where there are no other options. Now, Lenicappavir, I want to mention because the FDA is currently reviewing the data for this drug for heavily treatment experienced individuals. And it's exciting in a couple of ways. And the main way being it is super long acting, like it is being studied as a sub-Q every 6-month drug for treatment and for PrEP. It blocks multiple steps of the HIV pathway. The capsid is this shell that houses and protects the viral genome. It blocks nuclear transport of this capsid in the viral genome, disassembly of the capsid, and then also blocks reassembly and release of the capsid, so it blocks multiple steps. This is the trial that the FDA is currently reviewing called Capella. It was small, but people got 14 days of oral Lenicappavir, which was an oral dose at day 1, 2, and 8. And then on day 15, they were started on sub-Q Lenicappavir every 6 months, kind of a funky dose, 927 milligrams, which required 2 sub-Q injections in the abdomen. And then they were followed. There was a randomized cohort, though everyone ended up on sub-Q, and then there's a non-randomized cohort. The data we've seen and the data the FDA is reviewing is for this randomized cohort where everyone got to 26 weeks at on the every 6-month sub-Q. This is the data. Overall, you can see here the proportion that got to viral load below 50, the proportion that got to below 200, and the important finding that Lenicappavir worked well as long as there was at least one other active agent combined with it. Now, one issue is that resistance to this drug can happen. So while it's very long acting, right now, what it's generally being combined with in studies is oral ART. And if a person gets the long acting agent and doesn't adhere to their oral ART, resistance to the Lenicappavir can happen, and these capsid resistance mutations have been documented. There is a trial going on for treatment-naive individuals as well that has had similar findings. It's a potent, long-acting medication, but might be a little bit fragile. Resistance does happen, and so I think we need to understand better. Finally, and I know I'm right at time, islatravir is a long-acting drug. There was a question about the implant. Islatravir is a long-acting drug that may have some added benefit in the sense that it seems to have a higher barrier to resistance than Lenicappavir. It seems to work well even in the setting of NRTI resistance mutations, though there are some interesting interplays. It seems like it has heightened activity in the setting of K65R and some mutations we already know, and then there are some mutations that we aren't very familiar with that can affect it. But very importantly, it is being developed as a once daily pill, and that is in phase 3. It's a once daily pill combined with doravirine. So again, high barrier to resistance med in islatravir combined with doravirine. Also seems like this combo is pretty metabolically neutral. So that may be a new option in the near future for 2-drug maintenance therapy. Then there's also an oral weekly version of islatravir combined with this novel weekly NNRTI. There's once weekly oral islatravir Lenicappavir in phase 2, and then long-acting injectable islatravir Lenicappavir in phase 1. Coming back to the prior question, a yearly implant of islatravir is also being studied for PrEP, so there's a lot of excitement around that. So that is a preview of what's coming. I'm a minute over. Thank you for giving me your patience, and I will look to questions and comments.
Thank you so much, Brian, for that comprehensive talk. Always great to hear. I think I don't think you answered the question from Jihan regarding TDF versus TAF and shifting our thought process to TDF, given that there was some weight gain in the Discover for PrEP, TAF for PrEP at least.
Yeah, thanks, Jihan, for that question. So interestingly, in that trial, there were weight gain in both arms, in the TAF arm and in the TDF arm. What I often hear people say is, oh, then TAF causes weight gain. But I don't think we know that that's true. I still think it may have been TDF suppressing the weight. So perhaps people are gaining weight naturally and TDF has a suppressive effect. I just don't think we know. So I would not completely rule out that TAF has some direct effect. I just haven't seen evidence for it yet. Whereas I've seen a lot of evidence that TDF suppresses weight. And that makes me nervous to routinely switch people who report weight gain on TAF to TDF, because I don't think we fully understand what it's doing to mitochondria or why it's suppressing weight. So excellent question, and I think we need to learn more.
Thank you so much. I know we're over. So thank you so much, Brian, again, for that comprehensive review, as always. And thank you, everyone, for joining.
Thanks, everyone. Thanks for having me.